بسم الله الرحمن الرحيم. في الأول بحب أشكر أستاذ دكتور سامح توفيق على الدعوة، وبشكر التشير بيرسونز وزمايلي اللي معايا في السيشن. I'll start my case presentation. Female patient 6 years old presented at our endocrine clinic with appearance of pubic and axillary hair. It started 2 months ago. It is of progressive course. She is the first child of healthy non-consanguineous parents born at a term, non-eventful pregnancy. Her birth weight was 3 kilograms. She is of normal motor and mental milestones. No history of intake of any medications, especially steroids or androgens. No family history of similar condition. Systemic examination was normal. Her tenor staging bilateral B1, axillary hair A2, pubic hair B3, and no menarche. Her anthropometric measurements: height 112 centimeters on 25th centile. Her mid-parental height extends from 156 to 170. And as we can see, our patient lies within her mid-parental height. She is on the low normal. Her weight 23 kilograms on 75th centile. BMI 18.4 on 85th centile. To summarize, our patient, 6 years old girl, presented with pubic and axillary hair. Her height is on 25th centile within her mid-parental height. We started to think of a differential diagnosis of our case. Is it a case of congenital adrenal hyperplasia, either non-classic late onset or classic simple virilizing? Is it virilizing adrenal tumor or virilizing ovarian tumor? Or maybe due to exogenous intake of androgens, but this diagnosis was already excluded by history. Maybe central precocious puberty or isolated premature adrenarche, and it is diagnosis of by exclusion or of exclusion. We started to complete our puzzle by doing investigations. We started with bone age. It was 6 years and 6 months. Her chronological age is 6 years, so it's advanced only 6 months. Abdominopelvic ultrasound was normal, no suprarenal masses or cysts, normal sized uterus and ovaries, and no pelvic masses or cysts. We proceeded to do ACTH stimulation tests, and to interpret these tests, we have to know that the peak level of 17 hydroxyprogesterone shouldn't exceed 6.5 nanogram per milliliters in normal subjects post ACTH stimulation. Levels more than 12 are diagnostic of non-classic CH. A serum level of DHEAS exceeding 40 microgram per deciliter has been regarded as a whole biochemical hallmark of adrenarche. Again, if we return it to our test, we will find that the 17 OHP 4.4 within normal post-stimulation, and DHEAS 96, which is very high, exceeding 40. So again, if we return to our differential diagnosis, it's not a case of non-classic CH excluded by the ACTH stimulation test, not virilizing adrenal tumor or virilizing ovarian tumor were also excluded by abdominopelvic ultrasound. Central precocious puberty usually starts with normal sequence of puberty. Starts with development of breast and then appearance of pubic and axillary hair. While our patient started with pubic and axillary hair, she is somehow deviated from the normal progression of puberty, so it's excluded. So finally, our diagnosis, it's a case of isolated premature adrenarche by exclusion of all other causes. We will summarize what is premature adrenarche. It is maturational increase in secretion of adrenal androgen precursors, mainly DHEA and its sulfate. It was first described and published in early 1950s. The most pronounced sign of premature adrenarche is the appearance of pubic and or axillary hair, also associated with other signs of androgen effect, especially accelerated height or accelerated growth. It appears usually in mid-childhood, occurring at around 5 to 8 years of age. It is a benign condition. However, it's linked with unfavorable metabolic features, hyperinsulinism, dyslipidemia, ovarian hyperandrogenism. DHEAS is considered the best marker of adrenal androgen secretion. Premature adrenarche risk factors, intrauterine growth retardation, small for gestational age. Small for gestational age and low birth weight. These are the usual risk factors. It has a genetic background. Again, if we return it back to our case, we ensured the parents that their daughter has a benign condition. She just requires regular follow-up at 6 months interval. And during the follow-up, we found that there is marked advancement of hair growth velocity. She increased about 18 centimeters within 2 years, and she crossed from the 25th centile to the 75th centile. Hair bone age is now 8 years, corresponding to her chronological age, and her tenor staging was the same, no progression. Our learning points that the diagnosis of premature adrenarche is based on exclusion of other causes. It is of benign nature. Measurement of blood glucose is essential in premature adrenarche children with history of low birth weight or acanthosis nigricans, and the insulin sensitivity should be assessed if the child is obese or has family history of type 2 diabetes or metabolic syndrome. Lifestyle modification is the main line of treatment. There is shortage of data on the safety and effectiveness of long-term use of metformin or insulin sensitizers. The use of these medications is not recommended outside clinical trials. And finally, my key message to pediatricians: with every visit, you have to plot the child on growth chart. Advancement of height or deviation from normal pattern of puberty should attract your attention, and you must refer to pediatric endocrinologist. And thank you a lot for your attention.